There are, of course, with long-term conditions and people approaching end of life, a whole variety of different problems. And it's hard to know which of those problems are uppermost in people's minds. And actually, when we address the problem of what many people suffer of social loss, isolation, loneliness, through community development, then it's possible to see quite a large impact on use of healthcare services. So, in particular, there's a great project that was run is still running in Severn Hospice, in which the chief exec went out and trained community groups in non-hands-on care, and that he then linked up those community groups with GP practices, and so that the volunteers could then establish relationships with people who are most vulnerable, as identified by the GP practice. And the impact on that, and essentially it's about, visiting people's houses and seeing how they're getting on and offering support in a variety of ways, is that the impact of that is enormous, as you can see, is that, for that group of patients, reduced GP appointments, reduced ED attendances, reduced hospital admissions by more than half, reduced out-of-hours calls, and improved sense of health and well-being. And funnily enough, that goes for the people who are participating as well as for the patients. So and what that suggests is that there's a significant proportion of what people are bothered by, which is to do with not to do with specific healthcare issues, but to do with the problems that come alongside with them. And you can see that that same information is represented graphically on slide 16. So that the interest in community development has been ongoing for a significant amount of time now, and really kicked off in end-of-life care about 15 years ago by Alan Keller here. And that's been expanding ever since in all over the world, really. And it allows the use of the imagination to address problems from a whole different set of perspectives. And if thinking about the problems, is that what we generally see is that we have a horrific addiction to high-cost professional services, and because of that, that limits our way of thinking about new ways of delivering support. And that essentially, dying from a chronic illness is a form of speeded up aging. That when you hear people's stories, that there's an incredible similarity about the losses. It's perhaps harder to adjust to in the end-of-life setting because of the speed at which they occur. But the issues are essentially the same. And what you have is loss of mobility, loss of role, loss of sense of meaning and value, and increasing social isolation. I was describing this to an MP locally about what we were doing, and she said, well, I absolutely recognize this, because sometimes when I go out canvassing, I'm the first person to knock on someone's door for 6 weeks. And when you think of it like that, it's a kind of psychological torture, and that these problems won't be addressed by using professional services alone. Because if you have somebody who is not paid to come in and see you, but is coming to see you because they want to, that has a very different feel from somebody who's knocking on the door because it's their job. So that there's been this increasing interest over the last few years, and in particular, Alan Keller here has written the Compassionate City Charter, and I know Libby will mention this briefly. But essentially, the Charter is in Compassionate City and Compassionate Community, and essentially, it's a way of saying, look, we're all going to die. So why don't we work together and do something about it? And although it's not quite a checklist, it is gives a broad overview of the different type of things that need to be done. And essentially, it's about how communities can help. So on the one hand, you can think about public health approaches as community engagement, which is about conversations. And the other side is about community development. And that's saying that it's not just talking about it, but what can we do to help? And in particular, that we have surrounding us naturally occurring supportive networks of varying size and varying degrees of closeness to people. And so what can we do to actively work to enhance those naturally occurring supportive networks? Because if we think about, you know, ourselves and who we are and what we do, is that we get meaning and value somehow from the way we relate to the people around us and the way that they relate to us, and that essentially the experience that people have around death, dying, and loss is one in which they are able to do less and less, and weakness and fatigue as particular issues. And that as they're able to do less and less, that they're able to do the things that they recognize themselves for being human. I mean, if we all think about ourselves and think about, you know, if we couldn't do certain things, that we might feel less valuable, that we might feel more of a burden to the people closest to us, and that we might lose a sense of who we are. Because in addition, you know, we're going to see, we have to deal with the emotions of loss, of separation from loved ones, often have changing bodily appearance, and they're huge demands. And if you think about the surrounding networks of the people who are around us, and think about that, what that would mean for those people to support us. When we were feeling perhaps really negative about ourselves in one way or another, and think about not just supporting us if we're the person with the illness, but supporting the carer who we may be, our main carer who we may be worrying about. So that actually then goes back to our first slide, which says actually, you know, that has a significant impact in a whole variety of different directions, and actually allows us to make the most out of the time that we have remaining. So that the Charter is a way of thinking about all the different sectors where we can enhance naturally occurring supportive networks. And that goes from workplaces to schools to educational institutions to religious institutions to unions to museums and galleries to, in fact, the networks occur wherever there are people, and of course that's everywhere. And so this is a conscious attempt to actively engage with the networks and increase them, so that if you are ill, if you are a carer, if you've suffered a bereavement, when you walk into your working environment, there are people already there who you know you can talk to and who will help out and support you. Okay, that's probably the right moment to hand over to Libby now. That sounds good. Just say when you want a new slide, Libby.
I will. Great. So it's really nice to have this opportunity. We got to the point where we're even having this webinar. How have we got to the point that community development has become such a kind of a buzzword, really, and such a topic that is on many people's lips? And I think there are a number of reasons for this, a number of drivers for change that have been developing really over the past kind of 30 or 40 years, but have really taken hold over the past, say, 5 years. And some of the key drivers for change, I think, within health and social care, and particularly within long-term conditions, have been the recognition that actually professionals, although we have a huge amount to share, do not have all the answers, and actually there are limitations to professional knowledge, and that communities often possess the answers about how best to help them overcome specific health and barriers that they're facing. Demographic and funding pressures are really significant and are forcing people to look for new and innovative ways of meeting the needs that people present. And there's this real appreciation of the fact that biomedical issues and kind of technological interventions are not the only factors that influence health, and particularly health and well-being, and that actually social factors such as your environment, where you live, what barriers are allowing you to make or not make healthy decisions, have a huge impact. Top-down approaches have often been realised that they don't realise to not make sustainable change, and upstream interventions, so kind of early interventions, public health interventions, which involve stopping people getting into that situation that they're in, rather than just focusing on curing and resolving issues later on, is a much better strategy for improving health and well-being. So particularly within kind of compassionate communities and stuff, it's around thinking, how would we stop someone having complicated bereavement at the beginning, rather than just thinking how we manage a very complicated bereavement. It's thinking, what could we do upstream to actually support them to have a healthier bereavement? And the fundamental to this is that health is everyone's responsibility. Next slide, please, Julian. And really importantly, for this area, the evidence base is now building. Whereas before a lot of it was anecdote, it made sense, and people had great experience from their local projects, but there are some really large studies that have been published over the past 3 or 4 years, which have really lent weight to the fact that engaging with communities leads to really tangible outcomes. And I'm just going to go through these three papers are freely downloadable. They're open access, so if you just type in the title and the author that I've included and the year, you'll come straight onto the free full text. The first one, which was a huge study, a massive meta-analysis done by Holt and Lundstad and colleagues, and there's a lot of evidence around not having a strong social network caused increased mortality, and they wanted to know, was this true across a large number of studies? So they pulled together over 100 studies, and they found out that having a poor social network is as dangerous as smoking 15 a day, as not taking up cardiac rehab following an MI, as being obese, and having a strong social network, a really highly functioning social network, can further 50% increase survival likelihood. So this was a kind of really seminal study to demonstrate social networks have not only improvements on kind of well-being and kind of self-efficacy, etc., they actually have an impact on your mortality. The second one is by Revital and colleagues, and they looked at more specifically, so long-term conditions, what impact is having a good social network, particularly people with diabetes and heart failure. And they demonstrated that having a strong social network improves your mental and physical well-being, but also results in significant cost savings in primary, secondary, tertiary level care, because the formal network actually take over and perform a lot of the roles that otherwise formal care would step in to control. And there's some really convincing economic evidence within that paper. And then the final one is another large meta-analysis, which was done about a year and a half ago, and by an NIHR-funded project. And this demonstrates that engaging communities has solid impact, a positive impact on health outcomes, behaviour, self-efficacy across a whole range of different projects. So this is things like smoking cessation, increasing breastfeeding rates, increasing cancer screening. So a huge range of different projects, but they've demonstrated that all projects that engage communities in this work have much better outcomes than those who don't. So this kind of research and kind of evidence-based building has really supported people within end-of-life care to think, well, wait a minute, maybe there's something in this for us. Next slide. Thank you. And this is the main person who has kind of, as Julian alluded to, been thinking around this is Alan Kelleher, an Australian sociologist who has moved to the UK. I'm sorry, the slide is a bit jumbled up. But he first described the public health approach to end-of-life care, or health-promoting palliative care, in 1999, where he said, we should learn from health promotion, and there are a huge amount of kind of different lessons that we can learn through palliative care to engage communities. And he came up with the term compassionate communities through his book, which was published in 2005, which is a picture of it there. And he says that compassionate communities are community development initiatives that actively involve citizens in their own end-of-life care. And the key word there is citizens. And this isn't about involving patients as patients or carers as carers. It involves involving people as individuals, as citizens with rights and responsibilities, and as members of a community. and everyone has the responsibility to take part and support their own and others' health at the end of life. And it's around building partnerships between services and communities, and rather than just going in and replacing everything with new professional care, building on what's already there and saying, where can we fit in around the gaps? What do we need to help here? What can we support that actually may have been happening for years, supporting this person in their own home? Next slide. If you keep pressing it, Julian, lots of different things come up. So we'll leave it there for a second. So these two pieces of research came out a couple of years ago. One was a survey that I undertook with a colleague. We asked all palliative care and end-of-life care services, do you know anything about the public health approach? Are they priorities for you? Do they mean anything? Are you doing anything under this banner? And over 90% of hospices and end-of-life care services said yes, these are a priority for us, either now or in the future. Next one. National Council for Palliative Care and Dying Matters and Murray Hall Community Trust published this booklet, which is an overview of compassionate communities throughout England. And this, again, is freely available on the Dying Matters website, or if you Google that title, it comes up as a free PDF to download. And it's a really interesting overview of all the different projects that are currently underway. And there's a huge number of different projects that are happening. Next one. So Pathfinder Community was supported by National Council for Palliative Care to underpin their Dying Well Charter. And within this is a toolkit, press the next one, Julian, which was written by Owen Kelleher and is kind of most up-to-date reflections on public health approaches. And this is a big, big document, but a really useful guide for people who are thinking, I'd quite like to start something like this in my local area, in my local service, and it really takes you through all the evidence, all the reasons why, and then how it would look in practice. And this is underpinning the Pathfinder community, which is a series of 8 different sites who are exemplifying the public health approach, are being linked together to form a network. And within that toolkit that Alan has written is the Compassionate Cities Charter that Julian mentioned before, and so that's where you can find it within that. Next slide. The Cabinet Office, the government have obviously kind of taken interest in some of this, and so there was a recent call for applications for a large pot of money to support volunteers, befriending and social action at the end of life. So people are sitting up and realising it has significance within government. And final one, Julian, is the Public Health Conference. So in May this year in Bristol, we'll be hosting, the UK will be hosting the 4th International Public Health and Palliative Care Conference. They started in Kerala in 2009, have gone through Kerala, Bangladesh, Ireland, and we're hosting it this May. And this will be an amazing opportunity to hear about public health approaches throughout the world within end-of-life care through a series of workshops, through presentations and networking. We've got excellent representation from all around the world. I think that's my last slide.